focused constructs. So that's what we're trying to do through our little community here. And the way in which we do that is through a lot of different things. We have our systems-focused group meetings, which is what we're doing here. Sometimes we may have conference calls. We don't do that too often, but we leave ourselves open to it. Resources and tools that we provide to you, which I'll kind of show you where we keep those. Your email-based discussion group where you guys share events or resources or ask questions of each other through your Google group. And then the Center for Excellence is always available to give technical assistance should you need it. Oh, I thought I had more to talk about this, but I'll just do it on this slide. So the resources and tools from the meetings are posted on the New Hampshire Center for Excellence website. So if you go to the little communities of practice bar, there's one that says prevention, and then we post the slides for the day. We post the recording of the webinar. For the people that are remote, we record it. And we also capture all the questions that you ask throughout the day, type up the answers that people give to you, and then we post that. So if you don't remember and you're like, I know I asked about that, what did they say? It's on the website. That's also where you can provide technical assistance. And if you have any questions about the Google group, we have an FAQ up on this table, which is kind of like a resource table. I just brought some things from your past meetings. If you have anything you want to put there, feel free. We also have our Google group FAQ there. You can also ask me any questions. And then this group also has a contact list that you guys had requested that Melissa's been pulling together. So we have 2 copies of it. If you recently feel like you looked at this and made sure that your information was correct, you're all good to go. But if you recently changed jobs, or you got a new email, or you got a new title, or you haven't looked at this before, try to make time before you leave today to come check out. We have 2 copies here to just make sure that it is up to date, and then we can update your information in the contact list so that you guys can better communicate with each other and build all that collegiality and community. So what we're going to do today is do our welcome instructions. That's what I'm doing now. Then we kind of just lumped this all in here, but it is a lot more than just this. We're going to kind of do a bit of presentation, a little bit of an activity, come back to presentation, another activity, have some discussion, back to a little more talking at the end, but we just kind of lumped it all in there, but it's going to flow pretty well, I think. And then I'll come back at the end to remind you about your evaluations for CPS credit. We have 2 hours available today. So the objectives of today's meeting is to describe the program that will be presented by Jamie Hobecki about the City of Manchester related to some data work that they did. And then we're going to compare the Manchester process to the feasibility in your own communities. And then we're going to inventory data sources for information related to the social determinants of health in your community. So these are kind of going to be done, like I said, through activity, through discussion. So before Jamie comes up, I'm going to have Jill come up and kind of set the tone for the day and introduce Jamie and talk about why this is the meeting that we're having today and how it relates to the work that you all do. And we do have wipes to sanitize the microphones. I'm going to give Jill the clean one while I sanitize this one so we can be safe.
Thank you very much. So I am really pleased to have this presentation today. So I heard Jamie present at the Commission on Mental Health and Education. It's a study committee that's looking at what is currently happening within our public school districts and how we can better meet the needs of our students and their families as it relates to behavioral health. And the presentation that Jamie and Mary Steady from the Manchester School Department gave just really resonated with everything that we are trying to do currently and that all of you are always have been doing, as looking at your social determinants of health and as it relates to behavioral health issues, substance misuse particularly, and how is it that we can meet the basic needs of our families and our students, because if families are prepared to meet the needs of their children, and if children are prepared to come to school ready to learn, then we are so much further down the road. So oftentimes, I've said this a number of times, that we concentrate on the substance, our last 30-day use for marijuana, alcohol, non-prescription drugs, etc. But what we really honestly should be looking at is what we learned early on is Maslow's hierarchy of needs. If your basic needs are being met, then everything else begins to fall into place. So Jamie and Mary and her group have done a fantastic job doing a case study within Manchester. And so she's going to present on that today, but she's also going to talk to you about how can this be applicable in your regions and how can this be replicated. I know resources are scarce, but there are avenues and opportunities that we can leverage to make sure that a similar process can happen. So with that, I would like to invite Jamie to come on up and present. Jamie is with, Jamie, I have to, in full disclosure, I called you Julie for the longest time because I've become my father. My father just named people whatever came to his mind. And I kept saying when we were doing the planning meeting, I'm like, Julie did a fantastic job from the Manchester, Public Health Department. They're like, we don't know a Julie. I'm like, no, you do. And so they're like, Jamie? I'm like, could be. That could be her name. Yeah. But Jamie is with the Manchester Public Health Department. She's the chief, I have it up in front of me because I'll call her whatever I want to call her, the chief strategy officer. So we're really, really pleased that you're able to join us. Do we have another clean? Okay.
Alrighty, so in the interest of full disclosure, I did not travel to any of the infected areas, Italy, or any of those things. So everybody should be safe. Anybody travel to Italy? No? Nobody wants to admit it. Okay, so I'm not kicking you out. So thank you, Jill, for the introduction. As was mentioned, I work at the Manchester Health Department. I've been there for about almost 17 years. And when I started, I actually came on, I have a health education background, so I came on to start the New Hampshire Institute for Public Health Practice, local public health practice that has offered classes locally in Manchester now for several years. We've been on a little bit of a hiatus lately, but they include things like core concepts and epidemiology, environmental health, and also a little bit about public health preparedness. After that, I transitioned into, I don't know if I'm, is that me doing feedback? Okay. All right. So after that, I transitioned into a role that was more around assessment and public health planning. And I did that for a little while. And really what it was from a health department perspective was solidifying our commitment to chronic disease prevention. Because as a department, a local health department, we have a lot that's been happening for, literally over 100 years in the way of food safety and inspections, and also infectious disease. But chronic disease always took a back burner. And when chronic disease takes a back burner, so does the social determinants of health, because so much of what we know pertains to chronic disease, also pertains to social determinants of health and risk factors and things that a local health department and local public health in general should be really setting its foundation on. So for us, it was really a shift in acknowledgement that we should be centering that as a focal point within our department, and have since solidified a branch that's focused on neighborhood and family health, which is huge for us because it really solidifies that commitment to social determinants of health and getting upstream on the work in Manchester. Fast forward, I ended up going back to school, getting my MPH at Boston University. Anybody go to BU? No? What's wrong with you people? You should go to BU. BU is a wonderful school. I attended down there because they offer social and behavioral sciences in particular. And that's something that I feel like in our state is lacking a little bit in our MPH programs. And I'm hoping that over time we can sort of broaden the horizons for what's available locally here in New Hampshire as well. And then I moved into the Chief Strategy Officer role under the direction of Anna Thomas, who's the current Public Health Director. So today, as was mentioned, I'm going to talk a little bit about the public health approach, which I know I'm speaking to the choir. This is not going to be a presentation that I think is going to be novel to any of you in the room. I think what it's intended to do is to just reinforce us coming back to the practice that we all learned when we were in school or during our reading and exploration as practitioners. around what are the common steps that we take. And in public health, that's assessment, policy development, and assurance. And so we're going to use this evidence-based framework for decision-making and really think about assessment, policy development, and assurance as we go along. The first few slides that I'm going to be showing are really to just set the foundation for today. So I know you all understand that there's a broader definition of health that we should be using. Does anybody, without looking at the slides and cheating, want to say what health means to you? Stacy, don't make me call on you. Yes.
State of mental, emotional, physical well-being.
Great. Anybody else?
It also measures a level of risk and protective factors that an individual and a community and a family may have.
Yes, great. So essentially, we've evolved to think of health as not just the presence or absence of disease, is what I'm hearing in both of your descriptions, that it's so much more. And there was a time when we didn't define it that way. We thought you were healthy if you didn't have disease, and we assumed that you had what you needed to support your daily life. And also, along the way, we thought that you could always have the option to make the healthy choice, which I think we've changed our understanding of that as things have been defined. I prefer the IOM's definition, which you can see up here, is the state of well-being and the capability to function in the face of changing circumstances, because the changing circumstances in particular can be a broad array of things. And it doesn't have to be health specific in terms of going to the gym or eating a healthy diet. It could be mental health related and personal well-being. It could also mean my past and what I've already faced and how I plan to move that forward for me in the future. Really what we're all speaking to is the socio-ecological model of health, which is a complex interaction of biology, behavior, and the environment. And as I mentioned, this wasn't always the case, which I feel like when I look at this, I'm like, duh, right? Like, of course, this is what would cause someone's health or their livelihood to happen, because it's not just about the individual themselves and the behaviors that they're interacting in this layer here. It's really about their friends and their family and social networks and what they're exposed to, which then becomes social norms. It's about their living and working conditions. In Manchester, this plays out when we have, as an example, a mom who has a family, single mom, no car, transportation, and she's having to shop at the corner store primarily for the food in her household. Even if I say to her, you really should be eating a healthier diet and this is what it looks like, she's going to be limited by what that corner store offers. So it's really more about what is happening in this layer as well. And then our broader social policies that you know exist out there. So from a health insurance perspective, we know that giving everybody even health insurance doesn't necessarily dictate their ability to stay healthy or be healthy, but it is a factor that is a part of this larger context of accessibility that needs to be a part of our modeling. So as I mentioned, I went to school a long time ago. I was thinking about this morning. It doesn't seem that long ago, but it was 20 years ago, and it feels like it totally dates me, back in undergrad, community health education. And at that time, we were taught that the Prochaska model of behavior change was the panacea for changing population health. And I don't know if anybody knows about the Prochaska model, hopefully you all do, but basically it's stages of change. So basically what it was saying is that folks will move across the spectrum of pre-contemplation to action, and then move along into maintenance, and eventually then they've changed their behavior, whether it's smoking, drinking, whatever that is. And we know now that what has happened is we sort of have this risk factor or risk behavior area. All of our interventions were primarily targeted here when I was graduating from undergrad. And now we know that as I mentioned in the other model, there's so many other influences and targets for those interventions that if we were to stay here and only tell somebody that, you know, the risk factors for smoking are incredibly challenging, so you should stop quitting smoking, and I'm going to teach you how to do so. If that was it, then probably most people wouldn't smoke. You know, there's other factors that we should be looking at. So all of our initial public health interventions, or most of them, really stayed in here, and we worked more closely with clinical care primarily in some of the approaches. Today, we're really looking more at the social and neighborhood conditions and also the societal influences that I mentioned. So for that person who might be smoking, for them, they could have grown up in a household full of smokers. And so for them, from their family's perspective, it was more of a norm for them. And they thought that that's just what you do, that folks smoke and that's acceptable and that could be for me. Or you grew up in a neighborhood where there's a lot of advertising, the corner store around tobacco products and the ability to access them. And then it becomes, again, more of a community norm. Everybody in my neighborhood smokes, why wouldn't I smoke? So there's pieces that are bigger than the individual, and sometimes that healthy choice is not an option for that individual. So we've got to really think more critically about our interventions and move them upstream. Also, in the same school of thought, we've learned a lot about adverse childhood experiences or events. And I really like this diagram showing the tree because it's, again, about the individual and the experiences that they've had in their life. And we know that the more adverse experiences a child has had, their risk for certain diseases and conditions increases. Now, I want to emphasize risk, because it doesn't mean it's a 100% given fact that if somebody experiences these things, that they will have disease, but their risk certainly increases if they have. But also what I like about this tree in particular, sorry, my left hand is horrible with I feel like I keep getting you with the dot. I want to take out your eye. Up here is really about the individual. And then again, you can't separate out the environment of where that person lives and all of the things that could be holding them back, whether it's discrimination, violence, poor housing quality, all of those things can affect and impact a person's ability to lead a healthy quality life as well. And from this research, as I'm sure most of you know, they actually were able to trace it back and follow folks over time and really look at those who had 4 or more ACEs in particular on that other slide, how high their risk got for certain health conditions. And as you can see here, there's a 4.6 increased risk of depression alone for individuals who have experienced 4 or more ACEs from the tree slide that I showed you. That's huge. That's huge. And so now that we know that, for us from a public health perspective, why does that matter? Why does that matter is because the social and behavioral sciences should be a part of our daily practice. And we should be thinking more critically about the moments of intervention and also our approach moving forward so that we can really understand why somebody might be experiencing depression from their trauma and past history, and then what do we do about that? Also, just from a basic public health perspective, I want to point out this even comes back on the traditional chronic disease chronic diseases and conditions that we see, like diabetes, heart disease, and cancer. It even elevates the risk among those diseases as well. How many people have seen this model? Okay, so good group of you. So my favorite thing about this model, and this is something that at the health department we use all the time now, is because what it did was took all of what I just said, which sounded, in my opinion, a little bit more anecdotal, right? People are like, well, it could be, maybe. There's one study, the ACEs study, that could link some of the social and behavioral sciences to health. And it looked at the evidence that's out there and boiled it down to 4 different categories of what would define someone's health. And it actually ascribed percentages to those categories. So right here, you have healthy behaviors. Here, social and economic factors, and physical environment. Those 4 categories are the buckets that determine someone's health status. And then they took it a step further and said, for healthy behaviors, 30% of an individual's health status is determined by those healthy behaviors like tobacco use, diet and exercise, alcohol use, and sexual activity. And then what they did down here is they looked at social and economic factors. And they said these types of factors here, education, employment, income, determine somebody's health status by 40%. And then the physical environment, another 10%. So when you add that up, you have 80% of what's determining someone's health status is outside of our healthcare delivery system. Yet we spend the most time talking about access to health services and care, and also spend the most money in terms of access to healthcare and services. That's only 20% of someone's health status. So really, this for me is flipping that model on its head and turning it over to say, we need to be paying more attention here in the social and economic factors as public health professionals, and really understanding root causes and drivers and designing our interventions appropriately so that we can get upstream. What I'm not saying at the same time is that this isn't important, because it absolutely is. It's a part of what determines someone's health status and should be a part of our discussion in terms of what types of interventions we want to design as public health professionals, but it shouldn't be where we zero in. And I hope I'm not slighting our clinical partners in the room, because certainly the clinical work that's done every day is a valued part of someone's health status. It's really just about getting upstream and thinking about that individual sitting in the doctor's office, listening to that doctor say, you have diabetes and I need you to follow these dietary recommendations. And then knowing that person's going back into a neighborhood in Manchester that doesn't have access to those healthy food options. That's where public health comes in. That's where we can help people follow these clinical care guidelines and recommendations that are being had in those medical offices. So I'm going to pause just for a second and see if anybody has any questions or comments before I proceed. Again, hopefully that wasn't groundbreaking. That's just sort of setting the foundation for where we're headed. So right now I'm going to start talking a little bit about the evidence-based decision-making model for public health, and really thinking about, again, assessment, policy development, and assurance. So if you're looking at that model for decision-making, there's one area in particular that talks about population and community characteristics and factors. That really falls in the assessment category for public health. So where do we start? We need to define the problem and understand the scope and magnitude of that problem within my community, and also how it's affecting the people. And the goal here would be to identify targets for policy-based interventions. So there's a worksheet that I'm gonna have you all look at. We're going to go through a little bit so you can understand what I mean about the appropriate targets. So the health problem analysis worksheet is something that is actually used in MPH programs today, and is something that Johns Hopkins actually relies on pretty heavily, which is the #1 public health school in the country. And basically, and I think Adelaide is, are you going? You go there. That's awesome. So basically what this is trying to do is get us upstream. So it's not enough for me to keep standing up here and say, upstream, upstream, think about root causes. It's a mapping ability for you all to really concretely think about how the health problems are occurring within your community or within the population you're trying to reach. So it steps you through from the health problem itself to what are the leading risk factors. Now, these are usually scientifically established. So you would go into the literature to understand your health problem and say, what are the risk factors that we know about from the research that's been done? And that would sort of be the level here. So a real simple one could be obesity might be my health problem here. And a risk factor here could be lack of access to healthy food. Could be like your nutrition side of things, healthy eating. Then the direct contributing factor column here also tends to be scientifically established, and that relates to the risk factor itself. So all of these are kind of like, I equate it to peeling back an onion, where one layer relates to this layer, then the next layer relates to the next layer, and the next layer relates to the next layer. So if you can see, it's sort of working in a progression. So what this column would be is all of those scientifically established factors that relate back to the risk factor that you've listed here. So in the case of healthy eating, a direct contributing factor could be lack of access to healthy food sources or affordable food sources. And then here, the indirect contributing factor is really that crux of the social and economic factors slide that when I showed you the roadmaps model. And what it's asking you to think about is your own community's context. So for that example that I was just saying, lack of access to healthy foods, in my community, the reason for that is the transportation system is lacking. It's not getting folks to full service supermarkets, as an example. Or it could be the foods that are offered are not culturally relevant or appropriate to the population that I'm trying to target. Or it could be food is available, but it's not, people don't know what to do with it. You know, we've done farmers markets in Manchester, and it's more of that if you build it, they will come type approach, and it hasn't worked because folks have said, great, I have this food, but I have no idea how to cook it, what to do with it. It looks wonderful, but I'm just going to bring it home and it's going to rot on my counter. So it's thinking through those community elements and context to really then apply what your intervention could look like. So let's just walk through a couple of additional examples. Infant mortality, the risk factor for infant mortality that I pulled out here is low birth weight. That is something that's been scientifically established in the literature, and we know that higher infant mortality occurs when the higher rate of low birth weight also occurs. So anybody want to take a guess on a direct contributing factor?
For nutrition,
Yeah.
lack of access to doctors or healthcare workers, no medication, essentially.
Great. You want to? I'll just pass this over. That's awesome. You hit them all. That's awesome. So inadequate access to prenatal care is one of the factors for low birth weight. And then how about indirect contributing factor in my community? It could be the availability of daycare or transportation services so that I can't get to the prenatal care as a real issue for me. So if I stop and I say, all right, I'm just going to do this, inadequate access, and I'm not going to pay attention to this side of things, my intervention probably will look very different because I'm not accounting for the community factors here. What I might do in this arena is say, okay, I'm going to reach out to the provider practices and I'm going to make sure that women in reproductive family planning environments understand the importance of gaining access to prenatal care when they become pregnant, which again is something that we still should do, but that's not going to be sufficient enough to drive or determine or change infant mortality in its totality. All right, so substance use disorder. An existing mental health condition, we know, is a primary risk factor for substance use disorder. Inadequate access to behavioral mental health treatment, in particular, availability, accessibility, affordability of those treatment options, obviously impact someone's ability to treat their risk factor here. And then about the community, it could be not enough practices, it could be high wait lists, or it could be a high unemployment rate. So there's low insurance opportunities to pay for the treatment needs that, that somebody could benefit from. And then from a social perspective, it could be unemployment and disconnection to the community in general, which is further pushing on that existing mental health condition and might lead to substance use. So what we're going to do is I'm going to have you pair up and talk a little bit about the factors together. And ideally, you would be doing this with resources. And we're going to talk about that after. I'm kind of going to go backwards in the slides a little bit. but I want you to just sort of get a feel for using the worksheet and see how that goes for you, and think about your community and what sources of information you could potentially be using. Okay, so we'll give about 15 minutes.
Well, so there's like the high level and then the scientific community. I think we're probably working on a less using either one. We also we call this is which is nice to actually like piece makes you get specific.
For mental health that you can think you know, things like
what is our community facing size of these? So is it transportation? What is the social side of it? So those are it's hard because everybody goes straight to the so that's not what we council and address. So let's have our business partners here. What is the social partners that are part of this, those contributing factors that we can address. So it doesn't mean that access to care is not like a priority. We need to like break it down. We need to break it down to social so that can actually which means maybe we're finding our, it's hard.
layers of access.
This is what's nice about this life.
That's when you get to But why is that? Because parents typically go down because right, what's not considered all step back. So basically you're access free meals, lies. Gives them something.
I know, I got tripped up. You can't get tripped up. Like, I'm trying to find
Did you step in that? Why is that? And you may say, because parents, I don't think they see as
Yeah, I think it's the reason for this kind of worksheet, right? Is to break it down. Like you're just talking about, right? Just talking about how many factors, affordable place to live, access to but that's what's further this, right? Community environment, the social environment, what ends up being here, you know, so like, a lot of affordable housing, you know, access to affordable housing, that actually might be a direct contributing factor.
We just did the same thing.
I want to change. Why do you think? Or, you know, Yep. So I believe that. Yeah. So you're normally just and so that would be a question because I've never done it again like this. Health problem. So your health problem, your health problem, whatever you say you want to change. Well, it's easier to say like you want to change.
Right.
You want to change.
I'm just trying to think about what our area, right?
Well,
Factors
to access to your area. Oh, well, yeah, that's why is that? Well, because like, you know, our parents don't think it's bad. We think that is.
Like, you know, like this way, that's why it's like wide open.
Because like she said, because if you look here, risk factor, luxury apartment, let's say risk protected factor. This health problem is what it is you're trying to change. That's your goal. Then your risk protected factors, and how you can reach that goal. It's the exact same.
Right. I think that would be another direction. Curious, like how protected factors look like. Right. So you have to try to think Well, we decided to go with something we're not actually working with, we just came up with the story, which is about so we have it, we started contributing, we didn't actually start. We were thinking of multiple health problems, right? We were thinking how it contributes to multiple.
Yeah.
And that's, I think that's true. They just don't have this extra. I love how
So it comes down 4 or 5 students.
yeah, and like the extra. To get it. We were just sort of.
Yeah. You know, so what makes that? I love it. Yeah.
All right, everyone, we're going to bring it back in. All right, hello, everyone. We're going to bring it back in. I need a little drink. Then somebody might kiss, right? It's like the wedding. All right, so thank you everybody for taking the time to work together. Does anybody feel inclined to share what you discussed? Everybody wants to talk about what they talked about. Brave partnership in the back?
Yeah.
All right.
As an example, we use substance disorder as a health problem. We talked about one of the risk factors being specifically in this case an anxiety disorder, or especially an untreated, unmanaged anxiety disorder. We talked about some direct contributing factors as being parental conflict, low school community connectedness, and housing instability, as examples, and then started breaking things down.
Great, great. Good example. Anybody have anything slightly different from that they want to share? Okay.
So we also stuck with the health problem of substance use disorder, but we wanted to explore the risk factor of exposure to opiates or medicine through like a medical prescription, and dived into like one of the direct contributing factor might be a provider's awareness and or willingness of alternative pain or symptom management. So, maybe that was just the first option that was offered to an individual. And some of the indirect contributing factors we went through was, in that clinical setting, does the provider have time to build up that education or awareness? Are there concerns about insurance being able to cover the cost of alternative management? Are there social and media perceptions of what healthcare is that's influencing those decisions?
Great, great. So how did it feel using the sheet? Does it make sense to folks? Allows you to sort of lay it out a little bit. I'm going to go, if this will allow me to. Oh, I'm sorry. All right. So in doing that, sort of the next step would be, once you've sort of have your structure set and you've identified some of your contributing factors, your next step would then be to try to prioritize from there. Areas where you think more attention should be had, or perhaps your targets for your intervention directly. And then prioritize your list further based on some of the other factors that were listed in the evidence-based decision-making model. Those are things like the political climate and will to address the factor that you're looking at. Whether you have the resources, both fiscal and human capital and skills to address the factor that you're interested in. Those sometimes actually determine the intervention more than the contributing factors themselves, because you might identify that there's some contributing factor that is a real problem in your community, but you don't have a lot of control or enough resources to really make a difference or an impact. So at that point, you could recognize it as a part of your model, but it might not be where you're targeting your intervention. When that happens in Manchester, we certainly sort of keep an eye on that as a strong contributing factor to the health problem we're trying to address, because there might be other ways in some of the other intervention strategies that you could at least acknowledge that as a barrier. And it could be that from a policy perspective, you might be waiting for the state to pass a specific policy, and until they're able to do that, you can't move forward on addressing that contributing factor. But so make sure you acknowledge still that those things exist and keep them in your radar screen, and try to elevate them up in your other work by saying this work would be so much more impactful, Senator so-and-so, if we were able to pass this policy and legislation specifically, and show them the modeling and the framework that you've created to back that up. Also, what you would do is not do this in a vacuum. I think it's important to start and try to map it out like you did, but you would turn to the literature. So if you're stuck and you're like, I don't even know what the risk factor is, what scientifically established means, or where I could go for that information, you start to go to the internet, some of your professional resources and sources out there, making sure that they're all valid sources, Professional journals are obviously a really good place to look. I know a lot of people struggle with access to professional journals if you're not currently in school, so check with the universities. I know in Manchester, UNH will allow us to go into their library and look in their PubMed online access and use their subscriptions and download articles. We have to physically go there, which can be a limiting factor, but the fact that we're allowed to go there and use it for professional purposes is fabulous. So look at those opportunities where you live. For indirect factors, those are things about your community. There could be community health needs assessments that exist in your community. Hospitals are required to do them every 3 years. So look to the hospitals for needs assessment information. A lot of them do a qualitative survey among their patient population as well that can give you a little bit more insight on the population you might be trying to reach. You might also conduct your own interviews. Go out into the neighborhoods, walk them yourselves, talk to folks out on the street and get a feel for what they're living on a daily basis. And then lastly, national sources. I already showed you the roadmaps model several times. I promise I don't work for them. I feel like I should get paid to show this so many times. But this little schematic can be helpful. So up here, these, as I mentioned, are usually your typical risk factors. These areas in here, access to care and quality of care, tend to be your direct contributing factors. And then down here, the last sort of buckets of social, economic, and physical environment can either be direct and or indirect contributing factors depending on how you use them. So if you're stuck and you're looking at that blank worksheet and you're like, I don't even know where to begin, look at a model like this and start to get the wheels spinning on some of these categories here and see if they start to fit into your health problem. The last message about this is so important. Don't get stuck in it. I know some of you all had shared at some of the tables that it can get a little bit complicated and complex. And if you're anybody like me, like a little bit more type A, I like my boxes. I like things to be like very clear. Here leads to here, leads to here, leads to here. And when it starts to get muddy, you're like, but wait a minute, this risk factor also impacts this, or the direct contributing factor. Is that an indirect or is that a direct contributing factor? Don't get lost in it. It's a way to sort of work it out and put it on paper, but don't really get too overly obsessed with getting it right in every category. The point is to just get to an endpoint and start your brain thinking a little bit more upstream. And this is actually, believe it or not, I pulled this example about chronic disease risk factors. This was actually published, and I can't even follow it. It stresses me out just looking at it. So this was meant to try and help people understand chronic disease risk factors. So again, don't get stuck in the mapping. Really just use it as a tool to get things started. Also, there's some resources out there to think about in terms of indicators, measures, and sources. So again, from the roadmaps model, if you dig into the website, they actually have all of those buckets mapped out here that I was showing you on the side for social and economic factors, physical environment, clinical care, health factors. Then they say, how would you measure tobacco use? And for them, they chose adult smoking and then what the data source for that might be. So this can be helpful too in terms of the measure, because you might think more about the indicators or what data might be available in your community to then help define the problem. So if you also get stuck at the risk factor level, turn to sources like this that can help define what indicators are appropriate to measure that risk factor. And here it is in just a closer view on the social and economic factors in particular. So under education, that's so broad. Here they're defining it as high school graduation and some college. So now I'm going to just walk you guys through just a few examples of other assessment resources that are out there to help you define health problems within your community. And I'm sure some of you will be aware of some of these, if not all of these, but I think these are the resources in Manchester that we turn to more frequently. First and foremost, census data, the American Community Survey in particular, they had a website called Fact Finder that has since gone away, and now they have a new website that is trying to do something very similar, maybe a little bit more intuitive than it was. I know people are a little afraid of census data and American Community Survey data because the database itself you can get kind of lost in and then you don't know where you are anymore. So what I think they've done with the update, which is nice, is provide tutorials for access. So if you go to this web link here, you can actually look at video tutorials that will walk you through how to select the right geography, as an example, which I think in and of itself can be a little bit challenging if you've ever been to that website. But that's a good place to start because they have a lot of the social and economic data that you'd be looking for. And I can't tell you how many phone calls we field on a pretty regular basis at the health department of folks just asking for basic poverty rates. But it really is, it's already at your fingertips within the census data itself. So I encourage you to go there, play with it, poke around and learn. If you haven't already been there, it's a good resource for your community. The New Hampshire Department of Health and Human Services released a social vulnerability index a couple years ago, and it was using the census data. So that's also available on the Environmental Public Health Tracking website. And I think it's linked through Wisdom, actually, where you can go and see these data for your community pulled off of the American Community Survey and Census site. So it makes it a little bit easier to access. And then I'm going to talk a little bit about community health outlooks and then a couple of national resources. I did some screenshots. I think going in, relying on technology is probably not a smart decision. So I did some screenshots to bring it forward. So the first one is on the Wisdom website. How many of you guys know that the Environmental Public Health Tracking Program released community outlook profiles for your communities? Not as many as you'd hope because they're a great resource. So go to the Wisdom website. The link is down in the slide. It's at the bottom of the slide in front of you. And check out what's called Community Health Outlooks. And basically what they've done is pulled off the most current or common census indicators into social and economic factors, and also health outcome data when it was available, whether it was the YRBS, the Youth Risk Behavior Surveillance Survey, or the BRFIS data, the Behavioral Risk Factor Surveillance Survey, or other sources. And they've put it down into a community level of geography as low as they can get it. So on this slide, it's a little bit hard to see, but this is looking at Manchester, and in particular the Greater Manchester Public Health Region. And what it does, which I like, is pull out the indicator itself here, and then it tells you which community had the lowest percentage, and then which community had the highest percentage. And for Manchester, because we can get most of our data down to a tract level, it's telling me the specific census tract with the highest level of folks without a high school diploma, as an example. And this happens to be census tract 20 at 32%. So 32% of the people who live in census tract 20, which is a west side census tract, sort of near CMC area, if you know Manchester, 32% of them do not have a high school diploma. Now the highest for Manchester region is telling me Bedford. 2.8% of the population in Bedford does not have a high school diploma. So right there, I can quickly pull it out. I don't have to dig through the census maps and tracks. And all of this is available on that Wisdom website that I mentioned. Reports exist for these areas. So they've done it by regional public health network, and then by county when they can. For us, because we're the largest areas in the state, Manchester and Nashua were pulled out specifically. And I just want to point out there, because I feel like Marsha sometimes. I feel like I hear in the community, people are like, Manchester, why do you guys always get all this stuff? But I just want to point out that this is an epidemiological decision, not a resourcing decision. So the fact that we have over 110,000 people living in the city of Manchester alone allows enough statistical power for the state to do this for us. Just so you understand, giving them a little bit of cover on some of those decisions that are made. They're made based on epidemiology. But you can see there's network information here as well as county information that's accessible on Wisdom. For national sources, I would strongly recommend going to Community Commons if you haven't already. How many people know about Community Commons? Okay, good section of folks. So Community Commons is a national website that has a lot of tools available that have already been developed for communities, and also a section where you can do your own mapping and scorecard creation. So that you actually have to go in, create a login, and then it maintains your information as well. So you can create your own maps, you can create your own profiles, look at your own geography areas, and it will keep that as a part of your profile. And then it also links you to other national sources and things that are available. One example of that is the Vulnerable Populations Footprint. And if you haven't been using this, it's a pretty cool tool. What it does is create a composite measure of health status or risk for you based on social and economic factors. So basically, scientists much smarter than myself took the poverty information and the high school information and created a measure to basically say those areas with high poverty and high or low high school graduation, depending on how you look at it, are areas of vulnerability that we as a country should be looking at more clearly. And sometimes when you look at some of the federal grant applications, they actually require you to look at this measure and put it into the assessment work so you can define areas of vulnerability. Basically, what you can see here is a zoomed in area of Manchester. The red area is areas that have both of these factors. Orange is poverty. And then if there was a purple area alone, it would be high school. So you can see in Manchester, what this is telling me is I've got this pooling and concentration of poverty and low education right in the center city of Manchester. And in particular, the red areas have both. And we know from a health perspective, that means there's higher risks there. And some of our work should be more geographically targeted in those areas of risk. This is the state view. You can see there's little pools. If we were to zoom in, a lot of what you're seeing here is poverty related, but some of the communities actually have educational factors as well. So you can go into the tool itself and play around a little bit with your own geography and understanding. The model also allows you to change the percentages. So just because you're not seeing it at these high percentages doesn't mean it doesn't exist in your community. So if you're one of the people in here, if you live in one of these communities that looks like you don't have any risk of vulnerability, every community has risk of vulnerability. And you can go in and play with the percentages and see at what percentage does your area start to come up as a potential hotspot. All of this, and I meant to say this earlier as well when you're doing the worksheet, we're really zeroing in because public health tends to take the fun out of life. We tend to go right for the need. There's a lot of great things happening in communities as well. So even when you're doing your mapping, you can think about protective factors as a part of your model. It doesn't have to be just risk factors. And some of your direct and indirect contributing factors could be positive things happening within your communities as well. So don't forget that. That could be a part of that. And likewise, when you're looking at your data, there's opportunity footprints now. So vulnerable footprints, and now there's opportunity footprints. And what this does is look at the intersection of school proficiency, job access, and transportation, as well as housing cost. And for places that have great proficient schools, opportunities for jobs, and lower housing costs, you start to see the color coming forward, the purple color. So purple, dark purple meets all three of those categories. The lighter shade of purple, it's really kind of hard to tell on this slide, meets two of those indicators. And then the variance in between have some level of factor, whether it's access to jobs or school proficiency. So, and again, you can go into this tool and play with the ranges and really get to know your community and what opportunities exist and at what level of geography. And in some places where the data is available, you can get it down to neighborhood level. All of these things that I'm mentioning, by the way, can be accessed at Community Commons. So I just want to keep that thread for you. So if you go to Community Commons, all of these things are in there, including this tool, which is pretty handy. It's a community health needs assessment tool. So even if the data that's available in this system doesn't pertain to your community. Say it's just not available and it's not helpful for you. It's a county level and you're like, I don't care about county. I only care about my town. I would still encourage you to go and look at the indicators they're pulling out, because you might want to just replicate that model and try and find the data for your town more specifically, because this can be a good tool to say, how would I even define health at a community level? At a national level, they're advising you to do it in this way. And if your geography is available, you literally type in Manchester, New Hampshire, and they create a nice little snappy report for you that you can print out and look at a community health profile developed based on this system. So go here and play around with it and learn a little bit about the indicators and the places that you live. The last one I wanted to mention, I think this last one, is Broad Street. And Broad Street has some level of an affiliation with Community Commons. So you'll see Broad Street material on Community Commons. But Broad Street is really its own system. You have to go here and create your own profile again, but it contains and maintains all of the same things that Community Commons would: your geographies of interest, the types of data that you've created yourself, and what you've looked at over time. What I like here that they've done is they have this whole thing called Create a New Story. So they allow you to go in and pick out bigger buckets of interest to you, whether it's food access or ACEs risk in children, deprivation, and then you select your geography area. So for ACEs, I went in and selected, I think I ended up selecting Concord as the area so folks could see. I think this is Concord. And what it basically does is pull out automatically all of these little dashboardy tools here and displays them visually for you. And then you can further click in and explore it. Explore the data even deeper. But what I like about it is it's very visual, as you can see. So top 10 languages spoken at home. So they're actually using more of the word bubbling technique. So the bigger the word, the more it's spoken. So English here, and then you can see Spanish and French, Nepali. So it's a nice tool as well, so to be able to sort of steal some graphics and put them into more of an infographic presentation for your communities. So I strongly encourage you to go and play around with this tool as well. And again, they sort of call these stories. You can create your own community story about ACEs risk. All right, so I'm going to turn it over to Julie, my other name.
Does anyone have any questions about all that wonderful data that Jamie does?
Oh yeah, I should say. Does anybody have any questions? I just dumped a lot of data on you. Anybody have any questions?
On the average, like how recent within the last few years are those data?
It will depend on the indicator itself. So any census data tries to pull the latest 5 years worth of data that's available. Some of the others, it's, in public health, I think that's always the limiting factor. I saw a lot of 12 through 16 data on there. Some 19 is probably the most up to date that you could get it. But they do try to maintain the sites pretty regularly because they're viewed very often on a national landscape. So I don't tend to find outdated information on their website. But it's an important point to look at source. And then also when you're in there, some of them will default to the geography that is available. So as an example for Concord, I noticed there was some Concord level information available at a zip code. And then for some indicators, it was only available at a county level. So then what you were looking at was county level data. So there's always footnotes at the bottom that will display source, years, and geography. So pay attention to those factors. It's a good point. Any other questions? All right.
So we're gonna So what we were going to do next was at each of your tables, you have a chart here. And looking at the worksheet that you did earlier, right, you looked at a health issue and then some of the direct or indirect contributing factors. Those are kind of off the top of your head, right? You're assuming or making, or maybe you know your community and you kind of figured that out for your community. But how are we finding those? How can we confirm it? Or if it,
and show that that's really what it is. So if it's an assumption that we're making based on what we kind of know or anecdotal conversations, how can we go and really figure out if that really is a contributing factor? What is the data source? Some of the ones that Jamie has brought up today, our last community of practice, we looked at data sources. You know your local community, you're already looking at data sources. And how do you get it? And maybe you don't know. And that's okay. That's part of what we want to get out of here from today is I don't know how to get this. And I want more information around this. Because I want to figure out really what is the contributing factor so that I can make sure my intervention is the best fit for my community. Okay? So maybe you were working in pairs earlier, or maybe you're already at your whole group table, but we're going to just take this a step further and come together as a table and follow it down this line. So what's the health issue? We didn't put that on there. What is the health issue that you're working on? What was that contributing factor that you identified? And then where are we going for that information? And if it's a big question mark, that's fine. When we come back to the, when we report out, what we'd love to hear is, what is a data source that you learned of today from one of your colleagues at the table that you hadn't heard about and that you're gonna go try? Or what is something that you're still stuck on and you want the bigger group to help us think about and find a solution for? Is that kind of clear what we're gonna do next? All right, awesome, thank you.
Over here, ours is gonna fall over the place, to be honest. Okay, we talked about and some of the contributing factors were lack of resources, the family environment, coping skills, education.
Inside of you.
Oh yeah, it's right on the other side of you. Yeah, look for your board. Oh wow.
Yeah, I mean, like, I think that we said that.
There's also no
That's like that. So that would fall under.
well, like substance use disorder, but our risk factors can be favorable. Substance use contribute to housing. In your home, because that issue into housing.
I don't have a lot of RBS in my area.
Even the affordable housing is next to.
It wasn't usually had the ACEs communities, but that's really awesome. Yeah.
that's the problem. The problem is the problem with Broad Street. Those factors are favorable attitude towards substance use. And then a contributing factor would be access. That would be our
Sanborn has very good, they just found that it's directly talking to the board.
That's just came out.
I'm like,
Yeah, okay. That's interesting.
we get mental health.
Yeah, you have one of the characters.
So some of the factors are their family environment, their school environment, social skills,
You know, there's environmental.
What?
We have an epidemiologist
But so,
are you get that directly from them, or do you get that online?
and I would just wonder, yeah, well, and around the
Here, if they have a density analysis, like Louisiana, so you're gonna get somebody who's looking at CHI. Oh, yeah.
yeah, outlets that sell. Words or outlets that sell.
Now you find it's really good.
We're just here right now. It's beautiful and nice to be out.
That's why I think, right. She's been on right.
I've done a lot of reading, so you know, I'm working with like.
Well, I'm about to do an environmental scan. So that's one data source. That's more. So an environmental scan is when you go out and you observe the actual density. To gather other data to use the stuff that's in here. We're going to go look at the advertising site at a number of outlets that are in each community. And B, what is their advertising? So are they, you know, if they're having food outside their store. There's like this list of criteria. Or are they like policy? I don't know. I have to talk. They're like non-advertised.
Was there, but they're on there.
Yeah, maybe you don't know that they sell it, but sure, yeah. So that's just us going out and collecting suggesting criteria. It's related to
Some are referred to industries. Yes.
don't have a list of
Get some of the Department of Prejudice.
Oh, okay.
I know, like, we sort of asked a certain question. We wanted to know how many apparently, one of my SMPs asked for me. Yeah, and all I do is write them all, and it's like, some Department of Corrections.
So why are we asked about your
Another reason for favorable advertisement.
Oh, thank you. Have you ever lived in anyone who had a problem with alcohol? Yeah.
What's happening?
What was that?
High school students reporting things that happen.
Yeah.
So someone
Yeah, I was gonna say that doesn't surprise me. Well, then it hasn't changed. Right? So that's actually.
Once they're maybe respectively
Yeah.
well, that's the one that goes before favorable attitudes. So the one that's not on here is the risk factor. So this column would be the risk factor, which would be favorable attitudes. It's showing up two ways. It's showing up in the density of outlets, right? A lot of people are shops purchase our substances. So parents aren't monitoring, and it could be because they're for you. There's so many reasons why or they're like, oh, it's right up the a million reasons.
Really nice. How many? I know. You're back in time. These we can borrow.
Our response rate is back there. But it's a way for
Yeah,
somebody.
yeah. I didn't see that. It's a while ago. Yeah, of course, the only time like that was higher meeting, like, so this Sunday was
So they put
it's
it
like I have
out
this whole year.
but we also do these
I thought I told you guys, I'm sorry.
but we still only get about like of the population we only get 2%.
Well, only because I'm a little concerned, because I like on stuff. Wait, and I sign on stuff. That's why.
told everyone, I've done a lot of training, so I work on it. Yeah. So like again, like how do they gather that? Right. Is that from your office? Yeah. And is that
Every other year we might do about 20. We're not always interviewing the people we need to be. And I think this is too often. Some sort of here, maybe here, and then we're doing interventions based on right, and we're not getting here, and then rolling out these everything. You're spending all this time and money doing I think this is exactly what the drug free community is doing. Except for they have one this it's like gets even more specific. So we have to get to this very these pieces might all be the same, but when it comes to this, we we tend to veer towards the most environmental strategies so that we feel like we're mutually exclusive of the majority of the natural.
Okay, I'm sorry, I was having a really good conversation.
It's okay.
Okay. I think we're gonna come back together. Can you hear me? They're just ignoring me. All right, so let's bring it back together. Ani's gonna do a one shot. Thank you, Ani. Okay, so coming back together. The tables I went to, the conversation was pretty rich, so I'm hoping that we can hear from the group about some of the interesting data sources that you learned about, or some of the bigger questions or struggles we have trying to figure out what these more community, local level contributing factors are. Is there a table that would like to start? Oh, I hear some.
I'm being volunteered.
Yeah, excellent.
We should do it as we had great scribe there. So as our problem, we chose great drinking.
Sorry, hold on, I'm getting you the other microphone.
Can you all hear me while she's getting the mic? John, you can hear me. Oh. So we chose underage drinking as the problem, and then some of the contributing factors, there a social norm for around drinking, family norms and values, vendor server compliance, access to free, affordable, out of school time activities, positive youth development activities, or lack of access. Some of the data sources that we get our information from are like school surveys, like YRBS.
Community health needs assessment.
Focus groups, both community and youth focus groups. Continuum of care assets and gaps. State Liquor Commission reports, K through 12 school youth serving organizations. And then how did we actually obtain that information? Working with school districts, partnering with hospitals, environmental scans, asset mapping groups, online. I don't have my glasses on, state and federal sources, community, stakeholder groups. Question?
And maybe for I'm looking at the clock for the sake of time, perhaps moving, we can just do any new sources, because I bet a lot of us have some similar ones. Some news sources or any stumbling blocks, areas that we have questions, right? That we aren't able, but we want that data. And the table want to go next? Any volunteers?
Thank you. I want the white too.
I'll give you a clean one.
Okay. We also talked about underage drinking, and our contributing factors were access through density of outlets and lack of parental monitoring. So I guess only new ones we talked about were conducting an environmental scan. In our community, we do a community survey of adult perceptions and norms. And then we also talked about some focus groups for youth and parents. And I guess the only other thing that we chatted about was how difficult it is when you're region-wide or county-wide to really get the local data that you really need to really get to know the particular community. And I'm sure most of us share that, but I find that we are kind of stopping at sort of particular levels of data because we're not really able to access the communities the way we want to, because we are limited on time because we're spread so thin amongst 17 towns, for example. So to really be able to come up with the interventions that we feel like will really impact all of the communities, when we were saying that those indirect contributing factors might look different in every community. So even if the problem, the risk factor, and the direct contributing factor might be similar, when we get to the indirect piece or the local condition, is what we call it in drug-free communities, is looking different in each of those 17 towns, for example. So that was sort of a challenge that we discussed at our table.
Did anyone else?
So at our table, we looked at adolescent nicotine use and ends, and we identified many of the same data sources and talked about the issue of within a regional public health network as well to definitely geo-target our data sources and be appropriate. I think at the end of the day, the biggest takeaway was some of the needs that we still have are listening to our providers and letting them and finding out from them what they need and where they stumble. And then our insurance data, what in terms of adolescent nicotine use, what is a gap? And then I think at a state level, what I took away from everybody's conversation is really to triangulate our data sources to come up with a data profile depending on the source, but then to also make sure that we have our targeted group being part of that conversation in terms of what they need and what they want in terms of treatment modalities and options for them. So.
Next group. I don't want to do our group. I just have a question and yeah, I wasn't going to do our group because I think our data sources have already been set. But one of the things that came up for me was around data, like where do people or what's being collected for recovery data? So, and where would we access that? If it's already being collected, how is it being collected? Where is it being reported? Is that accessible?
What was the question?
Like, how many people, is it being asked or being collected, like percentage of adults currently in treatment have access treatment or are in recovery from an addiction? Because like one of the things, so we know possibly addiction rates, right? Maybe based on how many people were admitted to a treatment center or
at least for mental health centers collecting that data, and I Googled it real quick, and it seems like it's something that might be a universal.
I was just going to quickly say that they also do one for children at the community health centers, and we had that conversation with them about it, so thanks for mentioning.
Okay, so I think Jamie's going to finish up a little bit here. As long as I don't
I've been touching my face and my hair, and I should have like
At least I'm not standing at a conference podium. I don't know if you saw the person say, whatever you do, don't touch your face. And then she went to turn her page. She went, and I was like, it's great. Yeah. So I just want to wrap up a little bit of the conversation. So now you sort of have walked through the assessment process. Just to comment on a comment that was made about geography and access to data. Even the larger areas like Manchester and Nashua struggle with this. Sometimes data is only available at a network level, county level, and then there's lots of geographies depending on the project you're working on that have been made up over time. And then for Manchester, we have all we can do to sort of handle Manchester, which as I mentioned is 110,000 population alone. Never mind thinking about Bedford and some of the others that fall into our region, what capacity looks like there. So that is definitely a challenge. I think the national resources are really trying to do a better job to help folks get at least town-specific information or zip code related information, which would be town-based. And then, as I mentioned, census will give you some level of block information, census tract information as well. But those sources, as we know, are only as good as they are in their collection abilities. That's why you see a really large push right now, or should see a large push right now for a complete count for census and American Community Survey data. So it's really important for us to pay attention to that if we use that as a common source within public health. So now you have that information, what the heck do you do with it? So just really quickly, coming back to the evidence-based decision-making model, the best available research evidence is really where the policy development piece comes in. And in Manchester, we've been relying heavily on the What Works for Health database as a quick look at what the evidence says in terms of what's effective in communities for interventions based on the latest research. And so you can go to this website and pull down a dashboard like setup that allows you to look at those factors that we showed with the Roadmaps framework and actually pick out one area. And here I was looking at family and social support, and then ensuring access to counseling and support services. And these are the recommended interventions by category. So it will tell you here whether it's recommended or not and at what level. So you can see crisis lines. There's some evidence available within the research body to recommend crisis lines as an effective intervention. What I want to point out on some of these types of websites, unless it specifically says not recommended, it doesn't mean it's not recommended. It just means the research that is available right now is not strongly suggesting, and that strongly suggesting could be that they only have 2 studies that they looked at. So it's not enough for them to say they strongly recommend. So look at this for sure, but really what you're looking at this for is to make sure it doesn't say it's not recommended. And there are some items in here that are not recommended based on the research that is available. Also, I just wanted to mention that when you're thinking about some of the social and economic factors and the social determinants of health, what it forces you to do, they're complex issues, so it forces you to work with other players and other sectors that you wouldn't historically work with. And in Manchester, one of those partners has been the school district. So as Jill mentioned at the start, We've been doing a lot of work as a health department and helping to facilitate a community schools approach. And it took a while for people to get used to the health department interested in our education system, because why would health care about education? But we know as health professionals and public health providers that health is education is everything to health in terms of setting a foundation for success for that child and also the family itself. So we've started a campaign back in 2012 to work specifically within some of those hot spot neighborhoods, east side and west side of the city, and working with the elementary schools directly and bringing community services into that environment to support the students and families more comprehensively. One of which is working with our local federally qualified health center, Amoskeag Health, to put social workers directly into those school environments to work as a part of the team directly in the school setting. So they're employed by Amoskeag Health, working within the schools full time. And for us, I know that happens in other communities across the state as well. For us, it was really that recognition of breaking down the siloed systems, because the district could certainly employ their own social workers, and some of the schools do. But in this model, there's a direct linkage back to that primary care medical home, in addition to the school home, and then more importantly, the neighborhood home, and how does the family interact across that system. So I think when you're doing this type of intervention work and getting a little bit more upstream, just know that some of these interventions will feel funky because you don't necessarily control them. There could be other partners and players that need to take that lead role, and that's okay. We should still reach out and try to engage them in that work. Really quickly, design think approach. How many people have heard about this? Okay. Same tables. You guys are rock stars back there. So basically what this is a kind of weird way, in my opinion, of saying they've taken the business sector's approach to innovation and product development in particular, and they're trying to put it on social problems. So this is the space where evidence and innovation collide in a good way, I should say, maybe hug. So basically what that means is it's allowing us to think a little bit differently around our approach. And one area in particular is ensuring that you have the voice of the person or the target population you're trying to reach. And I can't emphasize this enough. This should absolutely 100% be a part of your assessment process, the intervention work that you do, and that goes beyond a focus group, because focus groups tend to just ask people what their needs are. It doesn't really ever ask them what the solutions are. And I can't assume anything in that environment based on just your needs. I need to understand a little bit more deeply. And that means I need to ask that population, what would you recommend? How would you impact this problem? How would you make a difference? And in Manchester, really quickly, we went door to door in the neighborhoods. And I personally was out going door to door, and I walked up on this house and their fence was ripped up. There was trash in their yard. The door was kind of off hinge a little bit. And I hesitated because I was like, oh boy, I'm worried about knocking on this door. I don't know if somebody's going to tell me, to go somewhere. And so I walked up, and I'm already in my mind thinking, wow, there's a lot of, blight. There's things that we could do in this neighborhood. And I have all my own ideas of what this person could need. Knock on the door. This woman comes. She's really friendly, and she was talking to me for quite some time. And it turns out when we started talking about everything that was happening in her neighborhood, and I said, well, what would you do to change all of this? And she said, I would put a parking ban, and parking's our #1 need. I'm looking at her like, out of all of these things I see in front of you, graffiti and smashed bottles, your fence is ripped up, parking, why is parking so important to you? And from her perspective, she was feeling like folks were coming into Manchester, parking in her neighborhood, which was just sort of adjacent to the arena and some of the downtown environment, and parking there because it was free, and going into Manchester and then coming back. And on their way back, she said, a gentleman the other night smashed that bottle on my sidewalk, and somebody ripped up my fence the other night. And here I am thinking, this poor isolated woman needs like a Mr. Fix-It or something to come in, or we need to do something with putting more trash receptacles in this neighborhood. That wouldn't have solved the problem. The problem from her perspective is really individuals coming into her neighborhood, parking there, and causing some of this
damage and disruption. And from her mind, she thought maybe a residential parking ban would be a good thing for that neighborhood. So that stays with me because I would never have walked up and gone, this neighborhood needs a residential parking ban. Never. Like, right? It's not what comes top of mind when you look at some of those issues. It really took asking that question, what would you do about it? What's your major need? And what would you suggest for us to get there? So absolutely have to take the time. And I know time is of the essence, but that will save us in the long run of the time of trying to do an intervention that's not going to work, and also the investment that comes with that level of an intervention. So this model kind of turns things on its face and says, start with the voice of the people, and then don't be afraid to innovate. Use evidence to inform decisions, but don't let it hold you back. There could be a really creative solution to some of these social problems, and don't be afraid to go there. And more importantly, don't be afraid to go there because you're going to use a QI, or quality improvement technique, where you're going to try it out. Do a pilot test first. Don't do a large scale, multi-million-dollar intervention based on an idea. Actually try it out, pilot test it, gather some data, see how it goes, and then if it's great, ramp up and launch out from there. If you're interested in learning more about Design Think, there's a couple of free resources online through Stanford. You can actually take courses online for free about this approach. And then lastly, and I know we're like we're like way really close to time. I just wanted to put a plug out there for the evaluation side, and some of it came up when people were saying, somebody over here was saying about the fact that programmatic data is available and it's just not found in one place. So always evaluate your model. I heard somebody say once, well, it's evidence-based, so we don't need to evaluate its impact, and that's not true. So just because it was evidence-based in Milwaukee and was effective in Milwaukee doesn't mean it's going to work in Manchester. So we always have to do some level of programmatic evaluation. That doesn't mean you have to do a randomized control trial that they may have done to basically say that it was successful, but you should always have some level of measure on impact for the interventions that you're doing. One framework to consider is called results-based accountability. I love it because it asks 3 questions, and I feel like makes evaluation more approachable. It says, how much did we do? Which everybody's comfortable with doing because that's how many people came to your workshop. Everybody collects that type of information as an example. How well did we do it? Which gets more at quality. So you guys came today, but how well did we do? Did we provide the workshop and teaching techniques in an effective way that you feel you can take them from here and apply them? And then is anyone better off? And that's really the ultimate outcome aspect of it. So if we were to follow you over time, we'd say, great, you came to this workshop. We did a pretty good job delivering quality based on our evaluation tools, hopefully that we'll be seeing. And then if we followed you over time, we'd say, did you use that in practice? And was anybody better off from your use of these techniques, as a very simple example. So check out results-based accountability. I feel like it makes it a little bit more approachable, and it also allows you to set up performance measure dashboards, which, getting to the point of somebody earlier around putting a centralized dashboard in place that collects programmatic information from lots of different areas, is something that communities can consider, and something that we're hoping to build in Manchester specific to substance misuse and substance use disorder in particular. So with that, I will end. So thank you very much for your time.
Thank you so much, Amy. So these are our upcoming meeting dates. They're on Wednesdays except for in November because of Veterans Day. So hold these dates. Will, as always, in the registration information, give you the location. And then on your way out, please be sure to give me your name tag and also your evaluation. We'll check it off. Your evaluation is anonymous, but we'll check off your name so that you can get your certificate for CPS credit. If you just drop it and leave, then we'll have to send you an email saying, did you drop it? I'm sorry, we missed it. We don't want to do that. We'll check you off and we'll get you your certificates about next week, I think. So thank you all for coming. Thank you.
Sure.